Thanks very much, Colin. The last time I spoke to Colin was about 3 months ago when I was FaceTiming him an echo of a baby in the middle of the night, a 31-weeker with transposed vessels, asking him, Colin, is this transposed vessels in a 31-weeker? Anyway, thank you. I'm off piece there. So I want to thank the organising committee for the invitation to present here today, although I wasn't overly enamoured by the title of the talk that I was given. So I am not a pharmacologist, and when I sat back and thought about it, I mean, it's such an important area of care, and something that we probably don't fully appreciate. So what I decided to do was, so I thought long and hard about how I would get this across today. I thought, the majority of us here are neonatologists. A minority, Carl, Fino, are pharmacologists and neonatologists. The majority of us here are neonatologists. So I thought I would just give you a general overview of my interpretation of the importance of the pharmacology of this area. And then I would just introduce a little bit the therapeutic options that we have, and then try and take it to the bedside around what we do and what we base our decisions upon. So bear with me as I run through this, because I will run through it. There's a lot to get through over the next 30 minutes or so. So it is a relatively unique problem that we're dealing with, and why? Well, etiology is very different to that in the adult world, I guess, in pediatric world. And then when we think of the heart, it's structurally, functionally, and metabolically very different to that of an older child, stroke adult. And we are dealing with shunts and things that they don't necessarily have to deal with. And the neonatal myocardium as well, if you think about it, it's very, very different. It's structurally lacking certain things that are important from a contractility point of view. There's decreased innervation, sympathetic innervation, and fewer adrenal receptors. So the immature myocardium, it's more sensitive also to changes in afterload. These are important principles as we work our way through the talk. So in simple terms, we know what an inotrope is. It increases myocardial contractility, and it has some vasoactive properties. And these can be variable, and these can potentially introduce that concept of inotrope afterload imbalance, where you end up causing a reduction in your end organ blood flow. A principle to bear in mind as we go through. And inodilators, I guess, improve contractility, have variable effects on dilatation as well. So in simple terms, for me, PK, PD, well, pharmacokinetics is what the body does to the drug. And when we're dealing with infusions per se, we don't really have to worry about absorption, but the other elements are relevant. And I would think, in simple terms, think about the volume of distribution and the clearance. Clearance, a really important concept. And these are the primary determinants of half-life, which again is an important concept. And then the pharmacodynamics, what the drug does to the body. And like anything, the actions of these medications can have very good effects and, unfortunately, unwanted effects. What sort of things do we need to think about when we think about inotrope or catecholamine infusions? Well, they are that. They're administered by continuous infusion. And typically, and I'll address some of the administration issues in a little while, but they do take a period of time to reach a steady state. And that steady state is probably somewhere in the region of 15 to 20 minutes once the drug hits the bloodstream. Okay, and the majority of us titrate to clinical effect. The drugs are rapidly metabolized, and the effects decrease once the infusion is stopped. So the half-life of these drugs is somewhere around 2, 3, 4, 6 minutes, excluding milrinone, which is a much longer half-life. And much of the work that we base what we do upon is extrapolated from the adult world, the pediatric world, and animal models. And the effects really are variable on the various target organs. And the response is not definitively related to the amount of drug in the bloodstream at the time. And that's an important concept to bear in mind as well. And much of the PK, PD work that I will show you, or a little bit of anyway, is from the late 70s, early 80s, and maybe the early 90s. So we're talking about 25 years ago, or thereabouts. So how relevant is PK, PD work done on a term baby in 1979 to a 23-week baby when you're standing at the bedside caring for that kitty? So important considerations. And really, if you look at it, there is no real consistent relationship between plasma catecholamine concentrations and target organ effect. And actually, I'll bare my soul here. I get frustrated sometimes when I see these tables of at this amount it does this, and at that amount it does this, and this amount it does this. And you're wondering then why, at the bedside, and it's not doing that amount, or it's not doing that. Or so, in actual fact, the response to the dose, it's relatively unpredictable. And yes, there are generalizations, I think, and they're important things to consider. But when you're there at the bedside caring for a baby, you've got to bear in mind all the other parameters that are involved as well. And these other factors that influence clearance, for example, things like sepsis influences volume of distribution, renal impairment will influence clearance of many of these drugs, and hence sepsis and therapeutic hypothermia, the drugs will act differently, and the body will behave differently with those drugs as well. So these are important things to bear in mind. And sometimes the thing we don't really give an awful lot of thought around is actually how we give the bloody things. What factors are influencing the delivery of the drug. And these are important principles, which I think, if it's the only thing you took away from today, I think this is critical. How the drug gets to the baby. And so you need to know where you place your syringe driver, the type of driver it is, the diameter of the infusion tubing, the inline filters, and other infusions that influence. Oops, sorry, Siri is talking to me. Other infusions that are running as well, so the carrier rate of those infusions, which can influence the delivery of the drug to the baby. So important things to bear in mind. And also, when we're dealing with small babies, we've got lots of other problems. We're talking about tiny volumes of fluid that are being administered at very low rates. And so you're wondering why you started that infusion at 0.15 mils an hour, it's an hour later, nothing has happened, because it actually hasn't even got to the baby yet. So you need to think about those very practical issues. So when we think about the drugs that we have available, well, I'm going to run through a list of them. This is from a paper by William a little while back, looking at the individual drugs and their primary function, I guess, in terms of inotropy, vasodilation, vasoconstriction, and those that have both effects. So this is the sort of table I spoke to you about. It is relevant. I'm sorry, I didn't mean to be flippant about it. It's very relevant. But actually, what's interesting in this is there's the use of the word proposed in a few of these sections as well, which I think is relevant as opposed to it being definitive. And as I walk through some of the tables in a little while, I've tried to focus pharmacodynamic aspects based upon randomized trials. So, for example, when we're looking at echo measurements, I'm not really enamored by, I did the echo when it was running at this rate, and I've done the echo when it's running at the next rate, and this is the change. I prefer to base my evidence on, I'm running something I'm not sure of, and this is the effect here, and this is the effect a half an hour later, and I'm running something here that I'm not sure of, and this is the effect now, and this is the effect a half an hour later. I'm not dismissing the observation work, I think it's really important. But when it comes to measurements that are prone to human factors, then I think you need to think about that as well. So in terms of the drugs that are used, this is data from the pediatrics group a couple of years back, showing that really in 2012, dopamine is still the most commonly used drug, followed by epinephrine in terms of inotropes and infusions, followed by dobutamine. And that's for term babies with hypotension. And when you look at extremely low birth weight babies, similar sort of pattern, dopamine, epinephrine, and dobutamine. And that probably doesn't come as a surprise to anybody in the audience here. And these are the drugs that I suppose we're most familiar with, the ones on the left side, as you're looking at it, and the ones we're less familiar with then are the ones to the right. And if you look at the relevant PK/PD data on all these, it's limited, okay? It really is. I'll show you some of it as we move along. But I thought perhaps the most important aspect of this talk was to look at clinical conditions that we're dealing with at the bedside and how these principles apply to what we actually do. So I thought I would work my way through these, bearing in mind each one of these is a half an hour talk on its own. So I'm from Cork, we talk quickly. I'm going to talk even faster. I'll try not. So, what's the current evidence base around the preterm transitional low blood pressure problem? Well, it's hard to believe there are 22 randomized trials now. And if you the bolded print refers to the drug that's used the most, and the one I suppose that we have most history with, dopamine. And you'll see it in comparison to other agents across the board with a number of systematic reviews. We have, if Adelina Palissi is in the audience, I apologize, I haven't put up the more recent dobutamine placebo trial for low SVC flow states. But there are two trials that utilize placebo. One, the work from Martin Kluko's group in terms of milrinone, and fantastic work that they've done on milrinone in terms of PK/PD work. And then Adelina's paper. So working through the evidence in relation to this, well, it's been around, doping's been around for 40 years. I always joke about this, but actually the joke is now running out because it's now I'm around longer than dopamine is around. But ages back when I said this, I was actually around less than when dopamine's been around. So, and dopamine's been around for over 40 years, numerous animal studies and lots of published work on it. And so we should know what we're doing with it. And this is some of the PK/PD work. The endogenous levels in babies are 10 to 50 nanograms approximately. And that's relevant for epinephrine as well, especially in the first hours of life when those endogenous levels are very, very high. So if you're doing PK/PD work on epinephrine and you're measuring potentially endogenous epinephrine as well. So I think an important concept to bear in mind. But to cut a long story short, when you look at these individual studies, and I haven't gone through them, they date back from the late 70s through to 90. There's significant variability in the clearance of the drug. Okay, anywhere from something like 40 to 120, so threefold difference in the clearance rates. And these are actually much lower than in the adult world and our pediatric world, and that's why the adult and pediatric world need to use lower amounts of that drug to achieve the same efficacy. So it's rare that you walk into an adult ICU and or a pediatric ICU and see a kiddie on more than 10 micrograms of per minute of dopamine. Whereas in the neonatal intensive care, you may see significantly higher rates being run, and that's to do with the clearance of the drug. But the last line here, we have no data on the most immature babies, the babies who are getting those drugs most frequently in our units these days. We have very limited PK data on dopamine. When it comes to looking at the individual pharmacodynamic aspects of the drug, well, undoubtedly dopamine increases your blood pressure. Not in everybody, but it's certainly more efficacious in volume and more efficacious than dobutamine at increasing your blood pressure. It has similar efficacy to steroids, to epinephrine and norepinephrine. When we look at end organ blood flow and measures of end organ blood flow, I'm going to go through the cardiac output measures shortly. That's okay, I thought it was my phone. So there are a number of studies which have looked at urine output and no change in urine output when you look at these. And there are conflicting studies around what we really want to prevent, which is brain injury. And 3 conflicting studies. And I'll walk through these quickly. These are the cardiac output measurement studies, which are randomized trials of one agent versus another. And with different assessments of either right, left, SVC flow, and then the outcome. And this is from Jean-Christophe Rose from about 20 odd years ago through to the more recent work of Nick Evans' group on milrinone use. And you see, just draw your attention to, in these blinded studies, dopamine having a reduction in cardiac output. No change here, and so on. So what I'm trying to get at is, it's variable. Dopamine doesn't necessarily cause an increase in cardiac output. And I think when we are starting drugs, we'd like to think that we would increase the cardiac output in those individual babies. Now, when it comes to measuring cerebral blood flow, there are 3 studies, I think, which have looked at this in terms of dopamine and inotrope use. And So different measures of cerebral blood flow used in each one. Xenon clearance technique by Gordon Greason way back along. Adelina Pellicier used near-infrared measures with the Nero monitor. And we most recently, as a subgroup of the HIP trial, have looked at dopamine versus placebo with near-infrared and have used measures of cerebral oxygenation and transfer gain function as measures of cerebral autoregulation. And we found no change or no difference between placebo and dopamine on cerebral blood flow. This was the study that I was alluding to. And what we did see was when you compared dopamine to placebo, and these were 32 babies, I think. This is before the drug started. These are the absolute blood pressure values with interquartile ranges. And this is following the commencement of the agent, whether it be placebo or dopamine. And not surprisingly, you see an increase in blood pressure when you start dopamine compared to placebo. And then when we work our way through the influence on RSO2 or cerebral oxygenation, no difference between placebo and dopamine when you commence either agent. And then when we looked at the percentage of time the RSO2 was less than 63 as a marker of cerebral hypoxia, in essence there was no real difference between the agents. And again, when we looked at transfer gain function as a measure of cerebral autoregulation, there was no difference following the commencement of dopamine. There are some well-documented neuroendocrine effects of dopamine compared to dobutamine, and we see this in this elegant study by Filippi about 10 years ago, where they showed a reduction in your T4 value following commencement of dopamine, T4 staying elevated with the dobutamine group. And in actual fact, when the drug was stopped, you see this immediate, relatively immediate rise back up in T4 following the cessation of dopamine. So other studies in this area, dobutamine, this is a placebo trial I spoke to you about, that part of the NeoCirc group, which were looking at the utilization of dobutamine versus placebo in babies with low flow states, babies delivered less than 32 or 32 plus 6 weeks, I think. And in essence, showing this is a measure of dobutamine versus placebo, and looking at heart rate and base deficit, and showing an increase in heart rate with dobutamine when it's commenced, and a reduction in base deficit when dobutamine is commenced relative to placebo. And this is just a summary. This is not related to this study. This is a summary of the PK work that's been done on dobutamine in the past. This is me extrapolating from the individual studies that I alluded to at the start of this talk. But the half-life is similar to dopamine, in around 2 or 3 minutes, so it's rapidly metabolized. And once you discontinue it, it's rapidly eliminated. These are threshold values, and you'll find these terminologies when you go looking at some of the data in this area. Threshold values being where you get an increase in your cardiac index or an increase in your heart rate, and these are the concentrations that people have alluded to in terms of alteration in these. But again, we're talking about a different population of babies, I guess, from these studies to the ones that we're most concerned about today. And this is the study I alluded to in terms of the population pharmacodynamics. And this is an excellent study, really, really excellent study, a pilot trial, and then 3 different dosing regimes of milrinone, starting at 0.25 milligrams per kilo per minute, or 0.5 milligrams per kilo per minute, and then looking at that data, extrapolating it from it, and bearing in mind that the problem of low SVC flow is in the first hours of life, that 6-hour window or beyond. So in essence, ultimately what Nick and Martin ended up doing was actually coming up with an infusion that was given over 3 hours, 0.75 milligrams per kilo per minute over 3 hours, and then a maintenance rate of much lower at 0.2, which seemed to optimize eliminating low flow states. However, in their subsequent randomized trial, they found no difference with this regime in terms of preventing low flow states. And here we see no difference in the low SVC numbers between the milrinone and placebo group. So where does that leave us? I'm not sure. Vasopressin, this is just out in the last couple of years, looking at the potential use of vasopressin in babies with hypotension in the first days of life. Really interesting paper. Have a read of it, because have a look at the blood pressure values that they were starting intervention at. Quite low and impressive. But small numbers, 10 babies in each arm, and no difference. And I would draw your attention to this paper from the pediatric world, and a lot of what we have extrapolated from is the pediatric world, but also we should take note of some of the potential worries or concerns that have arisen in the pediatric world. And this paper from Karen Chung from McMaster about 10 years ago, vasopressin use, suggested that it didn't demonstrate any beneficial effects in terms of prevention of hypotension, but there wasn't a statistically significant difference, but there was a trend towards worse mortality in the vasopressin administered group. So just bear that in mind, I guess. So summarizing the effects of these agents, well, this is my tabular representation of heart rate, blood pressure, cardiac output, and cerebral blood flow. Lots of areas where we have no data, and some where we have some conflicting data, I guess. So in essence, lots more questions to be answered, I'm afraid. Now, I am cognizant I'm moving on and running out of time, so I'm going to run through this quickly. In terms of pulmonary hypertension, the goal of pulmonary hypertension is to reduce pulmonary vascular resistance. And thank Afif for some of these slides as well. So the aim is really to try and lower PVR. Unsurprisingly, when you look at studies looking at dopamine, epinephrine, norepinephrine, vasopressin, there are no randomized trials of any of these agents. And there are some case reports of these agents. But the greatest body of literature now, I think, over the last couple of years has been moving towards milrinone. And we see an increase in the use of milrinone over the last number of years or so. This is from the same data I showed you previously in terms of hypotension and documenting those yearly alterations in dose or in agents that are used. From about 2005 onwards, you see this exponential increase in the amount of milrinone that's being used across these sites in the States. And these are some of the dosing regimes. If you look at the adult world, children, neonate, and this is the Primacore study, the post-op study of milrinone use, the neonatal pulmonary hypertension work that Patrick McNamara has done, and then the preterm work. And you'll see different dosing regimes across the board. Lots more information, I think, still to be gathered around this drug. And bearing in mind this is animal work, but a suggestion that in the animal world that the drug acts differently in the first days of life than it does a number of weeks out, suggesting that it can impair cardiac output in the first days of life in this animal model. But when we thankfully look at some of the human work that's been done, and Afif and Colm, I think, contributed to this work, you see an improvement in various parameters of oxygenation, INO use following the commencement of milrinone in babies who had significant pulmonary hypertension. This is work from the Rotunda in Dublin, and similar work from Patrick McNamara's group a number of years back in Toronto, showing an improvement following the initiation of milrinone. So really, what am I trying to get at? Well, we probably need to do a trial in this area, and Afif is leading this work on milrinone in babies with pulmonary hypertension, including Willem and myself as well. So currently enrolling a pilot trial, challenging to get babies in, but getting there slowly. And hopefully next year or the year after, Afif will update us on all this work. It's easy to finish up here because when it's newborn sepsis and septic shock, we've really little data to guide us, very little. You'll be familiar with these sort of algorithms in the Surviving Sepsis campaign, and interestingly in this guidance, which is the most recent, suggests that dopamine would be the first agent that's used in newborn shock and sepsis. Despite the fact when you look at some of the work from the pediatric world, epinephrine seems to be more effective than dopamine. Again, dopamine was associated with increased risk of death in the pediatric population in the setting of sepsis. So we see many of these. You'll see many of these sort of observational studies of I commenced the following agent and the following happened, and that's relevant info. But there's been one randomized trial recently comparing epinephrine and dopamine in babies with sepsis out of India, and their conclusion was that they had comparable efficacy and safety in neonatal septic shock. Now, I think that's probably a fair summation, but the problem is, have a look at the mortality rates, 70% and 80%. small numbers, but still, So, in essence, what I'm trying to say is I don't know, a little bit like what William had alluded to previously. So, in the setting of perinatal asphyxia, I suppose is the other area that we are often using agents in. We see these findings in ECHO. Some great work done across Europe on this area. But I think we need to think about the effects on renal and hepatic function that asphyxia has, and that potentially cooling has as well. So two separate entities which are both happening at the same time. And these are factors that we need to consider. This is called sucking up to the chair. So I didn't realize Eric was going to be actually the chair. Sorry, in my defense. But this is some work he's done on myocardial function in the setting of hypoxia and therapeutic hypothermia. And to cut a long story short, babies who, and these are the black dots, refer to babies who have had hypoxic ischemic insult. The boxes, those babies who are cooled. These are a normal thermic group. So you see a difference between the HIE group, regardless of whether they're cooled or not, compared to the healthy babies. And when you stop cooling and rewarm, you see a similar function thereafter. I guess some unanswered questions around the agents used, and I think probably some trials are certainly warranted in this area. When we look at asphyxia and hypothermia, and I'm finishing up now, no difference in the incidence of hypotension when you look at this forest plot from Cochrane. When you look at intervention, then you see there is a trend towards more use of agents who are in babies who are being cooled. So just to be, I guess, aware of that fact. And maybe there are other factors influencing the decision to start agents rather than just the blood pressure itself. So summing up cooling and hypoxic ischemic encephalopathy and the utilization of agents during this particular problem. The majority of the data we have is from the animal world, and there's fantastic work from Po-Yin Chung, Chloe joint in Edmonton, looking at these agents, dobutamine, melanone, epinephrine in a porcine model. If you are interested, please have a read of it, but there's little human data there. So I'm going to finish by saying many unresolved issues, and you're going to probably hear this throughout the meeting probably. Paucity of data, despite the fact that we think we know what we're doing. The doses are unpredictable, and the doses need to be individualized. I think you need to just bear that in mind as you start agents. And the clinical response to the infusion should be monitored closely. The lowest dose that you can get the desired effect should be the dose that you use.